So heart failure, what is it? Heart failure is the inability of the heart to work effectively as a pump. The heart is too weak to keep up with metabolic needs of the patient. So when the heart does not beat effectively, your blood volume begins to back up. This results in problems with lung congestion and systemic circulation. So is it always heart failure, congestive heart failure? No, it is not always congestive heart failure. And is it possible for one side of the heart to fail and not the other? Yes, it is. Because the two ventricles represent two pumping systems, it is possible for one to fail by itself. This does only occur for a short period, though. So some different types of heart failure. We've got left-sided heart failure. It was formerly known as CHF. Subtypes are systolic, which the heart contraction is not forceful enough. And then there's diastolic, when the heart doesn't relax enough to fill. Most heart failure does begin in the left ventricle, and it progresses to failure of both ventricles. It is caused, again, left-sided heart failure is caused by hypertension, coronary artery disease, and valvular disease that involves the mitral or aortic valve. It is indicated by decreased tissue perfusion from poor cardiac output and pulmonary congestion from increased pressure in the pulmonary vessels. It may be acute or chronic, and it may be mild to severe. With systolic heart failure, your heart cannot forcefully contract enough during systole to eject enough blood into your circulation. Preload and afterload are increased while the contractility decreases. Your normal ejection fraction drops from 50 to 70 to about 40% as your ventricles dilate. Blood begins to back up into the lungs, which causes some shortness of breath. It's often referred to as forward failure, because if blood can't go forward, it must go back. And then with your diastolic, the left ventricle doesn't relax enough to get sufficient blood to pump to the body. That represents about 20 to 40% of all heart failure. With right-sided heart failure, it is ventricular failure. It's caused by left ventricular failure, right ventricular MI, or pulmonary hypertension. The right ventricle cannot empty completely. Increased volume and pressure develop in the venous system, which results in the peripheral edema. And then high output is not as common. Your cardiac output remains normal or above normal, which is unlike your left and right-sided heart failures. It is caused by increased metabolic needs or hyperkinetic conditions such as septicemia, high fever, anemia, and hyperthyroidism. So your compensatory mechanisms they're gonna work on improving your cardiac output. So as your body senses that the heart isn't pumping as strongly as it should, these compensatory mechanisms kick in. It's the body's way of trying to maintain homeostasis. Initially, these mechanisms will assist in increasing your cardiac output, but eventually they will contribute to pump failure. So you've got increased heart rate, improved stroke volume, arterial vasoconstriction, sodium and water retention, and then myocardial hypertrophy. So how does your heart rate help with your cardiac output? Decreased tissue oxygenation is going to increase the stimulation of the sympathetic nervous system, which is your fight or flight. It is also going to increase the heart rate and the blood pressure. Because your cardiac output is determined by your heart rate and your stroke volume, an increased heart rate results in an increased cardiac output. If your heart rate becomes too fast, your ventricles can't relax and fill properly, which again is going to lead to your decreased cardiac output. So what about stroke volume? Your sympathetic nervous system, again your fight or flight, is stimulated. What this does is it increases venous return. which further stretches the myocardial fibers and results in dilation. We talked about Starling's law in the last chapter. It increases the myocardial stretch, which will result in a more forceful contraction, and that ultimately leads to increased stroke volume and cardiac output. Now, after a certain point is reached within the heart, further volume and stretch are going to reduce the force of contraction and cardiac output. So what about arterial vasoconstriction? There are good and bad things here. So your sympathetic nervous system, again, is going to be stimulated, which increases arterial constriction. Your adequate BP and increased tissue perfusion result from that constriction. However, your arterial constriction increases your afterload, which does require the left ventricle to work harder. So stroke volume may decrease, which causes your cardiac output to decrease. Sorry about the typo there, guys. So, activation of the RAS. The RAS is the renin-angiotensin system. Decreased blood flow to kidneys. When this occurs, your RAS is activated. Vasoconstrictive response to angiotensin II occurs. Aldosterone secretion is going to cause sodium and water retention. Because of that retention, your preload and your afterload are going to increase. So can you all see a trend? With all the compensatory mechanisms work to increase cardiac output, they actually eventually contribute to worsening heart failure. Don't forget about your myocardial hypertrophy. So the walls of the heart thicken to increase the muscle mass, which leads to more forceful contractions. Again, your cardiac output is increased. Your heart can hypertrophy faster than collateral circulation can occur. So hypertrophied heart is often going to be slightly oxygen deprived. Some other compensatory mechanisms that we do have an immune response. So pro-inflammatory cytokines are released, which contributes to ventricular remodeling. Your BMP, we talked about this a little bit in the last chapter, is natriuretic peptides that promote vasodilation and diuresis. B-type natriuretic peptide is going to be released by the ventricles when there is fluid overload secondary to heart failure. So some etiology. You've got hypertension, MI, structural heart changes, which include valvular dysfunction, or pulmonic or aortic stenosis, which leads to pressure or volume overload on the heart. Some risk factors for this are also listed in Table 35-1 on page 681. Heart failure assessment, guys. This is going to be really important for you to know, so be sure you know it. Left-sided heart failure assessment is in Chart 35-1 on page 682, and your right-sided is in Chart 35-2 on page 682. So, with your left-sided heart failure, you are going to have fatigue. You want to make sure that the patient describes to you their daily activity. Dyspnea on exertion, very important. They may also have dizziness when standing, important to know. Chest discomfort, obviously not surprising. Cough, you want to make sure that they can describe the severity, because there is a difference in severity depending on how far in they are with the heart failure. So early heart failure, they're going to have an irritating, nocturnal, non-productive cough. In severe heart failure, frothy, pink-tinged sputum, which indicates life-threatening pulmonary edema. That's obviously an emergency. And then we have your P&D again, the paroxysmal nocturnal dyspnea. Again, they will shoot up out of the bed in the middle of the night, feeling smothered and being panicky. This is really stressful. For your right-sided heart failure, Fluid retention and edema. So with fluid retention, you want to make sure that you are monitoring for hypokalemia because of dilution. They may have some abdominal distension. Jugular venous distension is important to know. Weight gain, nausea and anorexia, polyuria at night, and then hypertension versus hypotension. They may have either. So they will have increased systemic pressure and congestion in right-sided heart failure. Nausea and anorexia occurs related to their liver engorgement or liver congestion. And then with advanced heart failure, the late signs and symptoms of right-sided heart failure are going to be ascites, jaundice, and anasarca, which again is that generalized edema. So again, I really want you guys to understand these signs and symptoms for left and right-sided. So here we have a picture of left-sided heart failure. Again, it goes over basically the same things. They have the PND, elevated pulmonary capillary wedge pressure. I didn't really go into hemodynamic monitoring. I know you guys have been through it before, and it's not really necessary for what we're doing this week. So pulmonary congestion, cough, crackles, wheezes, blood-tinged sputum, again, that's an emergency, and tachypnea, restlessness, confusion, orthopnea, tachycardia, exertional dyspnea, fatigue, and cyanosis. Okay, so with your right-sided heart failure, it's also called cor pulmonale. They will have fatigue, increased peripheral venous pressure, ascites, enlarged liver and spleen, may be secondary to chronic pulmonary problems. Distended jugular veins is very common. Anorexia and complaints of GI distress, swelling in the hands and the fingers, and dependent edema. Psychosocial assessment, you're going to want to take a look at any debility that they may have. Anxiety, again, is going to be very common with this patient population. Dyspnea is common. Depression is common, just related to the fact that it's a chronic, debilitating disease. It's hard for people to deal with, which I can understand completely. Again, you want to understand their coping mechanisms. Are they out there trying to get healthy, or are they sitting at home smoking and drinking? I mean, I hate to say it judgmentally, and I'm not trying to be judgmental. The point is you have to know how they cope in order to appropriately treat them. Hope. Interestingly, your book talks about hope being a significant indicator of well-being for heart failure patients. So it's an extremely good sign if they do have hope. Conversely, if they don't have any hope, it's going to probably be harder on them. Your laboratory assessment, you're going to look at electrolytes, your sodium, potassium, magnesium, calcium, and chloride. This is especially important because of the use of diuretics. Chemistry, you're going to look at your BUN and creatinine. This is related to impaired renal function from the inadequate tissue perfusion. Your H&H. So, do you guys believe that hemodilution can affect the lab values? It absolutely can. So, H&H is used to identify heart failure that results from anemia. Hemodilution does cause a low hematocrit at times, so that's important to be aware of that. BNP, again, this is going to be used to differentiate between heart failure and lung dysfunction. Very important for you to know. BNP is used to differentiate between heart failure and lung dysfunction. It's used to diagnose that heart failure in dyspneic patients versus if it's a respiratory issue. Your levels may increase before the patient has symptoms. the benefits to this is obviously early intervention is going to be better for your patient. And then ABGs are going to monitor for hypoxemia. The patient may have respiratory alkalosis related to hyperventilation, respiratory acidosis related to CO2 retention, and metabolic acidosis related to accumulation of lactic acid. For your diagnostic assessment, chest x-rays can be very useful. They are diagnostic for left ventricular failure, and they also identify cardiomegaly. Your echo is going to be your best tool for diagnosing heart failure. As we discussed in that last chapter, the echocardiogram is the ultrasound of the heart. And then your EKG, it is not helpful in determining the presence or extent of heart failure. However, it may show ventricular hypertrophy, dysrhythmias, and any degree of myocardial ischemia, injury, or infarction. So while it doesn't determine heart failure, it can determine or rule out some other cardiac issues. Your interventions, you're going to monitor your vital signs and respiratory effort. You really want to focus on improving that gas exchange. Oxygen is given. You can place the patient in a high Fowler's position or elevate their head of bed. And then some people like to use that tripod positioning, so the overbed table is useful for that. So improving cardiac output, you want to work on reducing the afterload. So we talked about this in the last chapter. What is afterload again? That is going to be the resistance to left ventricular ejection. Medications that reduce afterload do not cause excessive vasodilation. However, they do reverse some of the inappropriate or excessive vasoconstriction. So your ACEs and your ARBs, your angiotensin converting enzyme inhibitors are your ACE inhibitors. So these prevent the conversion of angiotensin 1 to 2. I know you guys don't really care about that. It's just telling you how it works. This causes arterial dilation and increased stroke volume. So that's really what you're looking for. The ACEs are the first line drug of choice. Side effects. Do you guys remember the side effects of ACEs? So ACE inhibitors cause a nagging dry cough. So that's going to be what you're looking for with those. Now your ARBs, those are angiotensin receptor blockers. So they block the effects of the angiotensin 2, which decreases arterial resistance and dilation. And then they both block aldosterone. So some rules that are very important when dealing with ACEs and ARBs. You want to start low and go slow. Very important. You want to do an hourly blood pressure after the first dose or upon dosage increase. Immediately report a systolic blood pressure less than 90. And you can use the Trendelenburg position if you need to. Signs and symptoms that need to be reported immediately are going to be coughing, dizziness, and lightheadedness. There is a nursing safety priority on page 685 concerning these medications. Low systolic blood pressure, you're going to monitor for orthostatic hypotension, poor peripheral perfusion, and reduced urine output. Concerning renal dysfunction, you want to make sure that you monitor serum potassium and creatinine. Hyperkalemia may develop in patients that have impaired renal function, so that's really important to watch for. So here's your little cartoon on your ACE inhibitors. Again, I really want you guys to understand this cough that is associated with ACE inhibitors may warrant a medication change to ensure patient compliance with their medication regimen. Oftentimes, people have this nagging cough and they just really cannot tolerate it, and so they just quit taking their medicine. So obviously, rather than having them non-compliant with their medicine, we want to make sure that we change them if we need to. So your ACE inhibitors are going to include captopril, lisinopril, enalapril, and quinapril, excuse me. So wild card reaction, postural hypotension, fatigue, renal insufficiency, and cough. Here's another little cartoon on ACE inhibitors. So they decrease peripheral vascular resistance without increasing cardiac output, cardiac rate, or cardiac contractility. Again, your effects are dizziness, orthostatic hypotension, GI distress, non-productive cough, and headache. And you can see up in the right-hand corner, they end in pril. Okay, so HBNPs. So human B-type natriuretic peptides, or HBNP. These are used to treat acute heart failure. Natricor is an example. You give an IV bolus over 60 seconds, and then you may give a continuous infusion up to 48 hours. There is a nursing safety priority on page 685 concerning this. You want to monitor the blood pressure and pulse carefully. Significant decreases in blood pressure may occur. Very important. So, you may see a slow downtrending of the blood pressure, but the decreases can occur quickly. So you want to make sure, even if their pressure is still within normal limits, but you see it trending down, you make any adjustments as necessary. You want to make sure with Natricor that you give this medication through a separate line. It is not compatible with heparin and most other parenteral meds. And then your BNP is obviously going to increase after administration of this medication. So, improving cardiac output. We want to reduce preload. So what exactly does that mean? Reducing preload, your interventions are going to focus on decreasing the volume and pressure that's in the left ventricle, which is going to increase your muscle strength and contraction. You also want to focus on reducing sodium and water retention. So why do you think this is? That's going to decrease congestion and fluid overload that's going to be associated with heart failure. Your daily weight, again, you want to keep in mind that relation to fluid retention. 1 kilogram of weight gain or loss is equal to 1 liter of retained or lost fluid. So obviously that's a lot of fluid. And then medications to reduce preload can be used. They also help to manage the fluid volume. So medications that are used to reduce the preload, you've got diuretics, loop and thiazide. So your diuretics are going to eliminate sodium in water. Be sure that you monitor for hypokalemia. This is treated with a potassium-sparing diuretic, increased PO potassium intake, or they can take potassium supplements. You want to make sure they take this diuretic in the morning. You don't want them taking it before bed, because then, of course, they're going to be up out of bed all night going to the bathroom. Daily weight with these diuretics is very important. It helps to monitor that fluid balance. So with your loop diuretics, these are going to be furosemide, torsemide, and bumetanide. These work even after excess fluid is removed, so you've got to be wary and conscious that they may cause dehydration. With thiazide diuretics, these are going to be hydrochlorothiazide and metolazone. So diuresis with these decreases after the edema fluid is lost, and it is also a gradual onset diuresis. Your venous vasodilators, these are going to be nitrates. They are used for persistent dyspnea or acute heart failure. You have PO, IV, and topical preparations. You want to make sure with nitrates that you monitor their blood pressure and for headache. Nitrates can really drop the blood pressure. And then morphine. Morphine is used to treat acute heart failure. What it does is it reduces anxiety, it decreases the preload and afterload, it slows your respirations, and it also reduces the MI associated pain. So here we've got your diuretic cartoon. So it's the diuretic water slide. So you've got hydrochlorothiazide on one side, and you've got furosemide or Lasix. Your delivery routes are going to be PO, IV, and IM. And you are going to take these to help control edema related to CHF, cirrhosis, renal disease, and hypertension. It says on there not responsible for lost potassium. You want to make sure you're monitoring for that with your loop diuretics. And then again, you're going to watch for hypotension, low sodium, low chloride, low potassium, hyperglycemia, decreased weight, and decreased INO, and dehydration. So drugs that enhance contractility. I want to tell you guys, DIG is very, very prominent on your test. I want you to know the ins and outs of DIG. There are several questions over it, so just be prepared for that. So your digitalis increases contractility. It's going to reduce your heart rate. It inhibits the sympathetic nervous system. Again, that's your fight or flight response. It enhances the parasympathetic nervous system, which is what slows things down. You want to make sure you monitor levels of digoxin, as well as monitor for hypokalemia. That's going to potentiate your dig toxicity, and hyperkalemia is going to place your patient at risk for cardiac arrest. So very important to monitor a couple of things there. Your therapeutic level is 0.8 to 1.5. Some say 0.5 to 2.0. So in that range is therapeutic. You want to make sure that you know that range. You have a nursing safety priority on page 687. You may want to take a look at that. So digoxin increases the force of the contraction. You want to be sure that you hold the medication if the heart rate is less than 60. That is something you need to call the physician about. Oftentimes I've given DIG with a heart rate less than 60. It just depends on the patient and the physician preference. So it is a standard protocol across the board. You always take a manual pulse with DIG, and if the pulse is less than 60, you don't give it. You notify the doctor and decide, and find out what they want first. So signs and symptoms of toxicity that you need to be aware of: arrhythmias, visual disturbances, nausea, and anorexia. Again, I really want you to know the ins and outs of this drug. So here's your little cartoon for DIG. So you're going to watch for hypokalemia, hyperkalemia, visual disturbances, fatigue, arrhythmias, and anorexia. So DIG has the power to control cardiac output and ventricular response in AFib. You want to make sure that you get baseline vital signs, a full minute apical pulse, minimum of 60 beats per minute, and check your labs for DIG and potassium levels. Some other drugs that you may come across: dobutamine or Dobutrex, very, very commonly used. Milrinone or Primacor. Both of these medications are used to treat acute heart failure. They improve cardiac contractility, and they also improve cardiac output. Beta-adrenergic blockers or beta blockers. These are going to block your norepinephrine and your epinephrine from binding to the beta receptors. So beta-1 receptors are found in the heart, eyes, and kidneys. Your beta-2 receptors are going to be found in the lungs, GI tract, liver, uterus, blood vessels, and skeletal muscles. Beta blockers are very, very common. So here's your lovely cartoon about beta blocker actions. So beta blockers, the beta-1 receptors are going to affect the heart. Your beta-2 receptors are going to affect the lungs. Here is another cartoon. So your beta blockers, they end in olol. That's a good way to remember them. So they block beta receptors in the heart, which causes decreased heart rate, decreased force of contraction, and decreased rate of AV conduction. Your side effects are going to be bradycardia, lethargy, GI disturbance, CHF, hypotension, and depression. Okay, continuous positive airway pressure. This is going to be CPAP. So this improves obstructive sleep apnea in patients that have heart failure. Interestingly, your textbook talks about obstructive sleep apnea being linked to coronary artery disease because of the diminished oxygen supply to the heart during these apneic episodes. So the CPAP improves your cardiac output and your ejection fraction. It's going to decrease your afterload and preload. It's going to decrease your blood pressure, and it's going to decrease dysrhythmias. With ventricular assist devices, these are also known as VADs. So a mechanical pump is implanted to work with the heart. There are left and right-sided VADs available. These are used short-term while awaiting heart transplantation, or they may be used long-term for destination therapy. So destination therapy is going to be used to provide long-term support for patients that are not candidates for heart transplantation. So this is an image of a ventricular assist device. And here is another example. Okay, energy management. This is very important in patients that have heart failure. So, rest periods, you want to allow for those. Your activity in these patients is going to increase as their condition improves. You want to make sure to monitor their vital signs. This is very, very important for you guys to know. Remember this. If they have a change in blood pressure greater than 20 or an increase in heart rate greater than 20, then it indicates that the activity is too stressful. They're going to have activity intolerance. It's a problem. They do not need to be putting that much strain on the heart, so you need to take a step back in that instance. You want to monitor for other signs of activity intolerance. These are going to include dyspnea, fatigue, and chest pain. Pulmonary edema. So what are some manifestations of pulmonary edema? There is a chart 35-3 on page 688 in your textbook that you can look at if you like. So some of the manifestations are going to include crackles, dyspnea at rest, and disorientation or confusion. Very, very important. Documentation of lung sounds critical. Why is that, guys? This is going to help you identify fluid buildup. So you want to document the level of the crackles, because as the fluid builds up, it's going to ascend. So if we have crackles in the bases when we started, and now we've got crackles, halfway up, that's obviously showing that their edema is worsening. So some interventions. There is a nursing safety priority on page 689. It discusses high flow oxygen therapy to promote gas exchange and perfusion. The patient may even require CPAP, BiPAP, or intubation. I've seen this very, very commonly. Diuretics are going to be used. These are given, the rapid acting diuretics are given. So it's going to be like Lasix or Bumex. You can put the patient in the high Fowler's position. So nitrates, sublingual nitroglycerin. When their systolic blood pressure is greater than 100, you can give every 5 minutes up to 3 doses. This is going to help decrease the afterload and preload. Morphine, again, morphine is a very important drug. It reduces the preload, anxiety, and the work of breathing. A Foley is going to be placed to monitor diuresis and also to allow the respiratory status to recover or improve. And again, you may have CPAP, BiPAP, or intubation. Teaching. Prevent readmission. So obviously this is huge. This is something that we're really focused on in facilities right now. Very important to prevent readmission. And all too often, this patient population is going to be the one that you see every other week. I mean, these people come in all the time. So home management is very, very important. So the Joint Commission has some core measures that it's outlined. These include discharge instructions, which include information about their diet, activity, medications, weight, and the plan, what plan you guys have put into place. The core measures also include evaluation of left ventricular systolic function. An ACE inhibitor or an ARB has to be prescribed for left ventricular systolic dysfunction. And then again, very important is smoking cessation. So self-management teaching, MODS. MODS is an acronym for medications, activity, weight, diet, and symptoms. Very important for them to understand. Table 35-4, page 690. You may want to take a look at that. Advanced directives are really important. So 50% of deaths from heart failure are sudden, which is kind of shocking. That's a high number, I feel like. Really, really important to discuss advanced directives with the patients and their families. So your book talks a little bit about it. I think one of the other chapters we go a little bit in depth with it. You really want to make sure that your patient understands their right to make the decision for CPR or intubation, things like that. And you also want to make sure that once the patient has made that decision, that the family is on board. I know this is kind of hard in a hospital setting, but we got to do the best we can. And these decisions can be really difficult for patients to make. I mean, it really makes you look at your own fate and things like that, which can be hard. So you want to make sure that throughout this process, if you are involved, that you provide the patient with emotional support, and also you want to make sure that you support them in their decision, whether you agree with it or not. So when do we call the doctor? You've got a nursing safety priority that discusses information to report to the primary care physician. So, a couple of things. These are general rules. Rapid weight gain. This includes 3 pounds in a week or 1 to 2 pounds overnight. This is very, very, very important to educate our patients about. It's standard information. Decreased activity tolerance that lasts 2 to 3 days. Cold symptoms such as a cough that lasts 3 to 5 days, because again, that may be an indication of pulmonary congestion. Excessive awakening at night to urinate is important. Dyspnea or angina at rest, or dyspnea or angina that is worsening. And increased edema. Very important things your patient needs to understand. They need to report them immediately. Valvular heart disease. There are a couple of different ones. We've got mitral stenosis, mitral regurgitation, mitral valve prolapse, aortic stenosis, and aortic regurgitation. So, mitral stenosis, what is the most common cause of this, guys? Most common cause here is going to be rheumatic fever. Your valve leaflets fuse and become stiff. This leads to the valve opening narrowing, and in turn, the normal flow from the left atrium to the left ventricle is prevented. Key features, there's a chart on chart 35-6 on page 692. Excuse me. You may want to look over this. I don't expect you to memorize all of them. I will discuss what you need to know, but it would be good for you to take an eye at it. Take a peek at it. So, why do pulmonary congestion and right-sided failure occur? That's going to be because lack of adequate blood flow to the left ventricle causes your preload and your cardiac output to decrease. Some key features of mitral stenosis. Those key features are going to be fatigue, dyspnea on exertion, paroxysmal nocturnal dyspnea, hemoptysis, hepatomegaly, JVD, pitting edema, AFib, and a rumbling or apical diastolic murmur. So again, your blood backs up into the left atrium, which then is flowing into the lungs, and ultimately the right atrium. This causes your right atrium to work harder, again leading to the pulmonary congestion and the right-sided heart failure. So this is an example of mitral stenosis. I hope you guys can see the picture okay, but I think you can see where the occlusion is obviously worsening as you move right. Mitral regurgitation or insufficiency. Some primary causes of this are going to include degeneration related to aging, infective endocarditis, and rheumatic heart disease. So, incomplete valve closure during systole occurs. This leads to backflow of blood into the left atrium when the left ventricle contracts, and regurgitated output flows back into the left ventricle to be ejected again during the next systole. Again, there's that chart on page 692. Some key features include fatigue, dyspnea on exertion, orthopnea, palpitations, AFib, jugular venous distension, pitting edema, and a high-pitched holosystolic murmur, and an S3 sound may be present. So, why do the left atrium and left ventricle dilate and hypertrophy? So, this is going to occur to compensate for the increased volume and pressure present. Symptoms are going to be occurring when the left ventricle fails in response to this chronic blood volume overload. So patient is asymptomatic for a little while, and then eventually your heart just can't do it anymore. This is an example of mitral regurgitation. You can see the blood going where it's not supposed to go. Mitral valve prolapse. Your etiology on this is going to vary. There is a familial tendency. So the valve leaflets enlarge and prolapse into the left atrium during systole. It is typically a benign issue, although it may progress to mitral regurgitation. Again, you've got that chart on page 692. Your key features include atypical chest pain, dizziness, syncope, palpitations, atrial and ventricular tachycardia, mid-systolic click, and late systolic murmur that can be heard at the apex. So, do you expect patients to be symptomatic with this? As this is commonly a benign condition, patients are often not symptomatic. They will be asymptomatic. This is an example of that mitral valve prolapse. So you can see the valve malfunctioning, which is allowing that backflow of blood into the left atrium, and it causes enlargement there. Alright, aortic stenosis. Guess what, guys? This is the one you need to know. This is the most common cardiac valve dysfunction. This is the one you need to know more about. So, this is considered a wear and tear disease. The aortic valve orifice narrows and obstructs the left ventricle outflow during systole. This leads to increased resistance to ejection or afterload. Ventricular hypertrophy is going to occur and it eventually leads to failure. And the blood backs up in the left atrium and pulmonary system becomes congested as a result. Key features, this is really the one you may want to look at on page 692. So, some key features are going to be dyspnea on exertion, angina, syncope on exertion, fatigue, orthopnea, paroxysmal nocturnal dyspnea. It may also have a harsh systolic crescendo decrescendo murmur. When the surface area of the valve becomes less than or equal to 1 centimeter, surgery is indicated on an urgent basis. So, symptomatic aortic stenosis does have a poor prognosis without surgery. You want to be sure to educate your patient to limit their activity so that the strain on the heart is decreased while they are waiting for surgical intervention. So again, I want you to know the ins and outs of aortic stenosis and everything that we've just discussed. So this is an example of aortic stenosis. Alright, aortic regurgitation or insufficiency. Some common causes are going to be non-rheumatic conditions. Your valve leaflets do not close properly during diastole. Blood flows back from the aorta to the left ventricle. The left ventricle dilates to compensate, and the left ventricle hypertrophy occurs and leads to failure. Key features in that chart on 692. These include palpitations, dyspnea, orthopnea, paroxysmal nocturnal dyspnea, fatigue, angina, sinus tach, blowing, and decrescendo diastolic murmur. The patients, are they symptomatic, do you think? Oftentimes they are asymptomatic for many, many years because of the compensatory mechanisms of your left ventricle. So this is an example of aortic regurgitation. So it's showing you that blood that's leaking back. Some non-surgical management. We have drug therapy options. So medications are given to control the symptoms and maintain cardiac output. These may include diuretics, beta blockers, digoxin, oxygen, nitrates, and vasodilators. Rest is very important. So, what is required before any invasive procedure, do you think? Very important. This is discussed in the nursing safety priority on page 694. Prophylactic antibiotics are required before any invasive procedure. This is typically relating to dental or respiratory procedures. So the RN, it's within the RN role to instruct the patient to take meds as prescribed. You want to make sure that you teach them about the medications that they're taking, side effects they need to monitor for, and of course signs and symptoms that they need to report immediately. Monitor the patient for dysrhythmias. The physician may prescribe medications to control the heart rate in an effort to help maintain that cardiac output. Anticoagulation therapy in these patients is a very common occurrence. So non-invasive valve repair, there are a couple of different options here. You've got balloon valvuloplasty. There's a picture of that on the left. So what that is used for is for stenotic mitral and aortic valves. So your balloon is inflated to enlarge the valvular opening. And then with the transcatheter aortic valve replacement, it's also called a TAVR. That is for patients that are not surgical candidates. A bioprosthetic valve is going to be placed percutaneously via a transfemoral or transapical route. It follows the balloon valvuloplasty. So if they are doing this TAVR, they're going to do the balloon valvuloplasty first, and then they will percutaneously insert the prosthetic valve. You have a nursing safety priority on page 695. You want to make sure you monitor heart sounds, rhythm, and monitor for bleeding and emboli that may have broken loose. Very, very important. Valve repair, there are a couple of different ways that this can be done. So direct or open commissurotomy. This is going to be done in conjunction with cardiopulmonary bypass. The removal of thrombi is going to occur. The leaflets that are fused will be opened by the surgeon, and obviously that's going to widen the opening. A mitral valve annuloplasty, that's a little bit different. It's going to be reconstruction to prevent regurgitation. So you can see that picture where there's that tear that can cause the regurgitation. So they go in and place that annuloplasty ring, and it repairs that damaged leaflet. Valve replacement, a couple of different types of valve replacement. So there's prosthetic, which is going to be a synthetic valve that requires anticoagulation therapy permanently. Very important. I've taken care of many people that, are absolutely adamant, I've got to have my anticoagulation, and it's because it's a huge issue if they don't have that blood thinning. So the other option is going to be biologic, which is going to be tissue valves. Long-term anticoagulant therapy is not indicated, related to the decreased risk for clot formation. These biologic valves are less durable, so they may require replacement. Oftentimes they do. And they may not be used for aortic valve replacement because of the high pressure within the aorta. They cannot stand that pressure. So some education for valve disease. You want to make sure you always notify your physician that you have valvular disease. Antibiotics, again, are going to be required for all invasive procedures and tests. Very important for the patient to understand the medication regimen and that they are compliant with it. This is concerning the anticoagulation. They need to be sure to report worsening of symptoms or fever, petechia, or shortness of breath. And they also need to have an activity and rest plan. Inflammation and infections, there are a couple of different types. There is infective endocarditis, pericarditis, and rheumatic carditis. So with infective endocarditis, this occurs commonly with IV drug abuse, valve replacement, systemic infections, structural cardiac defects. Some ports of entry: oral cavity, skin, infections, surgery, and invasive procedures. This includes IV placement, which I thought was interesting. So the oral cavity, that is a portal of entry related to dental procedures that may occur. Some key features are listed in chart 35-8 on page 697. They include fever, anorexia, weight loss, new murmur or heart failure, systemic embolization, petechia, splinter hemorrhages, and positive blood cultures. So with these patients, they are at increased risk for thrombus formation. You guys need to know this. So infective endocarditis poses increased risk for thrombus formation. You want to make sure you monitor for signs and symptoms of complications. You're looking specifically for pulmonary embolism, so anxiety or chest pain. This is a medical emergency, so you really need to focus on that. With these patients, the mortality rate is high. Early detection is very essential for this condition. Your clinical manifestations usually occur within 2 weeks of the infection, so you'll start having those manifestations fairly quickly. So some interventions for infective endocarditis: rest, IV antibiotics, surgery, which would include valve repair or replacement or draining of abscesses. Home care, you want to make sure that you report signs and symptoms, have good hygiene. These patients need to take a daily temperature up to 6 weeks, and no flossing is allowed. Nursing safety priority on page 699. Again, you need to make sure you remind the healthcare provider of endocarditis related to potential need for prophylactic antibiotics, depending on what type of procedure you may have. Pericarditis, Etiology, acute versus chronic. So acute is going to occur with infective organisms. They are commonly respiratory, post heart attack, or post pericardiotomy syndrome. And finally, acute exacerbation of systemic connective tissue disease. I believe Marfan syndrome is one that your book talks about. So chronic pericarditis is going to be related to tuberculosis, radiation therapy, trauma, renal failure, or metastatic cancer. Treatment for chronic is surgical excision of the pericardium. It's kind of wild. Signs and symptoms. These include substernal pain. It may radiate to the left neck, shoulder, or back. And it is going to be aggravated by breathing, coughing, and swallowing. You may hear a pericardial friction rub. Some complications include pericardial effusion, which leads to cardiac tamponade. We'll get into that in just a little bit. Interventions are going to be NSAIDs, steroids. You want to make sure you place the patient in a position of comfort and make sure that you treat the cause. So here is an image of pericarditis. So you've got the pericardium, and then on the left there you've got the normal pericardium, and on the right you can see the inflamed pericardium is obviously much bigger than the normal pericardium. So cardiac tamponade. This is important. So you can see your pericardial sac there has fluid buildup within it. So it can be a buildup of blood or other fluid in the pericardial sac, which puts pressure on the heart and may prevent it from pumping effectively. So guys, cardiac tamponade is an emergency. You need to notify the physician immediately if this is suspected. So some signs and symptoms are going to include jugular venous distension, paradoxical pulse, which what that is it's going to be a systolic blood pressure that's 10 or higher on expiration than on inspiration, decreased cardiac output, muffled heart sounds, and circulatory collapse. So what is done to resolve this is a pericardiocentesis, which is the removal of fluid to relieve pressure on the heart. Rheumatic carditis, the etiology for this is it is a sensitivity response to an upper respiratory infection with group A strep. Causes inflammation in all layers of the heart. Some signs and symptoms include tachycardia, cardiomegaly, new or changed murmur, pericardial friction rub, precordial pain, EKG changes, indications of heart failure, and strep infection. Treatment for this is pretty basic. It's just going to be antibiotics. Cardiomyopathy, there are a couple of different classifications. These are listed in Table 35-5, page 701. So we've got dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. So again, you don't have to. You may want to check out that table on page 701. So with dilated cardiomyopathy, your ventricles are going to be dilated. Excuse me. The left ventricle is usually worse. Your systolic function is going to be impaired. Some causes of this are going to be alcohol abuse, chemo, infection, inflammation, and poor nutrition. So you have decreased cardiac output. These patients are going to experience dyspnea on exertion, decreased exercise capacity, fatigue, and palpitations. With hypertrophic cardiomyopathy, this is asymmetrical. It is left ventricular hypertrophy. So your left ventricle is going to be stiff, and there is going to be an outflow obstruction. So, do you think these patients are symptomatic or asymptomatic? Interestingly, mostly asymptomatic. So, athletes that die suddenly commonly die due to hypertrophic cardiomyopathy. Symptoms, if they are present, may include dyspnea on exertion, syncope, dizziness, and palpitations. Restrictive cardiomyopathy, this is going to be the rarest form. Stiff ventricles restrict filling during diastole. Symptoms include symptoms that are similar to left or right-sided heart failure or both. So some congestion, systemic congestion, edema, cough, things like that. This restrictive cardiomyopathy has a very poor prognosis. Half of the patients die within 2 years of the diagnosis. So this is just an image of the different types of cardiomyopathy. So you can see in the left-hand corner, you've got normal heart. And then moving right, you've got dilated cardiomyopathy, where the ventricles are going to be enlarged. Then you've got hypertrophic cardiomyopathy, where the walls of the ventricles become thick and stiff. And then restrictive cardiomyopathy, where the walls of the ventricles become stiff, but they are not necessarily thickened. So some non-surgical management for dilated or restrictive cardiomyopathy. It's initially going to be the same types of treatment as for heart failure. They're going to give diuretics, vasodilators, cardiac glycosides, antidysrhythmics, and beta blockers. They may require an implanted defibrillator. Teaching is very important. They need to understand to report palpitations, dizziness, or fainting because of the risk of sudden death. And they also need to understand to avoid alcohol. For hypertrophic cardiomyopathy, the non-surgical management is going to be a little bit different. You're going to give beta blockers and calcium antagonists. You want to decrease the outflow obstruction and the heart rate. And that's what the beta blockers and calcium antagonists are going to do. So vasodilators, diuretics, nitrates, and cardiac glycosides, are contraindicated. So this is due to the fact that vasodilating and positive inotropic effects may actually worsen the obstruction. And strenuous exercise is strictly prohibited in these patients. So for some surgical management, hypertrophic cardiomyopathy, they are going to do a ventriculomyomectomy. That's a mouthful. This is where a portion of the hypertrophied ventricular septum is excised. They may also do a percutaneous alcohol septal ablation. This is where absolute alcohol is injected into the target septal branch of the LAD to produce a small septal infarction. It is designed to reduce the obstruction to blood being ejected from the heart. So what it does, basically, this percutaneous alcohol septal ablation, is it creates a small controlled MI, which kills the area of the heart muscle that's responsible for the obstruction. So eventually that'll cause it to become less thick. Heart transplantation, post-op care, bleeding. The pericardium has usually been stretched related to hypertrophy, which may expose the patient to concealed bleeding, which means that there's extra room in there for the blood to accumulate. So you want to make sure you're watching for that cardiac tamponade again. So the transplanted heart is not responsive to vagal stimulation. That's important to know. Your heart responds slowly to exercise, stress, and position change. You want to monitor for orthostatic hypotension and also monitor for signs and symptoms of rejection. So with these patients that receive heart transplants, immunosuppressants are going to be prescribed. So these patients are going to be vulnerable to infection. Want to make sure they understand to avoid crowds and sick people. Infections, interestingly, are the major cause of death with these patients. So some signs and symptoms of rejection include shortness of breath, fluid gain, sinus brady, dysrhythmias, hypotension, weakness, and fatigue. And patients do not usually experience angina. And this is just an image of heart transplantation. So the recipient aorta and pulmonary arteries remain. The heart is going to be cut so that the diseased heart can be removed. And then you've got the recipient aorta and pulmonary arteries that, again, have remained. And you've got the donor or transplanted heart in place. And sutures are used to attach the donor heart. So it's just kind of cool to look at.